This quote talks about the critical need for classification of pelvic venous disorders and implications for both individual patient management and future clinical research. You can see these still images that I put into this slide of these large pelvic varices in the periuterine space and periovarian space. And so we need to better identify this patient population, the outcomes in this patient population, and how we're going to assess for optimal treatment strategy. Next. When we think about this disease and this patient population, obviously we know the three disease processes or the three underlying conditions that we need to assess for. The first being dilated ovarian veins, which are going to result in valvular insufficiency, ovarian vein reflux, or is this iliac vein compression. You can see in this still image the arrow pointing to the area of the left common iliac vein between the anterior aspect of the vertebral body and the right common iliac artery. And so the left common iliac vein can be compressed in that location. That can lead to backward or backfilling through the left internal iliac vein into the pelvic reservoir and lead to pelvic pain. And then we have renal vein compression. And so between the SMA and the aorta, the left renal vein obviously can be compressed in some of these patients. And that can lead to retrograde flow into the kidney, but it could also lead to collateralization and collateral flow through the left ovarian vein into the pelvis, which leads to pelvic reservoir dilation, can also lead to pelvic pain. So whenever we think about this population, these are the three that we look at. Next slide. This disease process has been evaluated by multiple groups of us, and we've gotten together in multiple aspects to discuss the best process forward. How do we understand this disease process? How do we improve the diagnosis, not just from the vascular population like us who perform high-quality interventions, but also the OBGYN community? And so who has venous origin chronic pelvic pain? And we have to think about other diagnoses that are being considered, one of which pelvic floor dysfunction, endometriosis, myofascial pain are big ones. And all of these potentially are going to overlap with venous origin chronic pelvic pain. So let's go to the next slide. When we look at how to identify venous origin pelvic pain, this is a slide from Neil Kilnani, who's actively performing a disease-related quality of life tool creation. So much like many of us know about in fibroid disease, venous origin chronic pelvic pain needs a disease-specific quality of life tool. And so that's in current development. If you look at this is during the development of that particular study. So it may not be in the latest stage and as the data gets populated and finished off, but it's currently being put together with differentiating between myofascial pain, pelvic endometriosis, and other disorders that cause pelvic pain compared to venous origin pelvic pain. And you can see the questionnaires that are being asked in each column and the overlap that exists of aching pain in the pelvis, as well as other disease entities. But the biggest one here is postcoital aching is really specific to venous origin pelvic pain and a disease-specific quality of life tool that is being assessed very closely as part of this study to prove that maybe that specifically is going to differentiate those with myofascial pain or endometriosis, so we can decide who really should pursue pelvic venous intervention, be it iliac vein stenting, ovarian vein embolization, combination, renal vein intervention, or none of the above in some of these other interventions. Next slide. So what I figured we could talk about is an upcoming trial that I've been working on for a number of years that we're at the point of finalizing funding, called the EMBOLIZE trial. And the EMBOLIZE trial stands for randomized controlled single-blinded parallel group trial of ovarian vein and pelvic vein embolization in women with chronic pelvic pain and pelvic varices. So what we're identifying, what we're targeting is those women with venous origin pelvic pain if we perform randomization between different interventions, one including embolization, one not, can we differentiate and improve the efficacy of this treatment and improve insurance coverage at this point? So next slide. So our inclusion criteria, like I was saying, we're really looking at a very disease-specific patient population. We want venous origin pelvic pain patients. So not only do they have to define as having chronic pelvic pain for a minimum of 6 months, so we know that this is chronic disease, they have to have a visual analog pain score of greater than or equal to 7. So it has to be severe disease. For those of you who've seen this female pelvic pain population who's had this for greater than 6 months, and I've seen them at 10 years, 12 years, 15 years of disease, they really are coming in with a VAS pain score of 9, 10 out of 10. They're coming in with severe disease. And really this is affecting them on a day-to-day situation. And we want to know that it's exacerbated by typical disease-specific processes. So walking, standing, lifting, anything that pressurizes the pelvic vasculature. It gets better when they lie down and elevate the pelvis, so emptying that pelvic vasculature. Postcoital ache, we said, was a disease-specific component that we think is key, so we're incorporating into this trial. And then absence of non-venous origin chronic pelvic pain, as determined by gynecologic examination. So we're going to have gynecologists pre-screen these patients, evaluate these patients, and if they think those other disease processes that I talked about earlier are the primary cause, then they shouldn't be included in this trial up front. You can see SVP classification, how it's delineated for the trial itself. Talked earlier about left or right ovarian vein diameter. So we need a dilated ovarian vein where valvular incompetence occurs. And then we want to see pelvic varices. So we want to prove, and part of the inclusion criteria is that these pelvic varices, you have to have at least one bigger than 5 millimeters in size, which is pretty easy to determine. And if you've looked at any outside imaging in these patients, you've probably seen that these are fairly large and you can see them pretty easily. Next slide. Important to know the exclusion criteria. I'm not going to go through these in great detail. There are 2 bolded ones specific for this trial, which I think is important. At that early slide, they showed the 3 components of disease, or 3 components of vascular disease or vascular disorder that can lead to pelvic venous hypertension, chronic pelvic pain. And so we want to exclude those in this particular trial. This particular trial, as I said, is focused specifically on ovarian vein insufficiency, ovarian vein reflux, and treatment following that pathway with embolization optimization, rather than looking at those with multiple components, which we've all seen and evaluated for, and will be a great point of discussion at some point. But you can see exclusion if there's iliac vein compression greater than 61%. We don't want to include those patients. So if pre-procedure imaging shows that iliac vein compression, those are not included in the study. Similarly, renal vein stenosis, we don't want those patients included in this trial either, because it's going to lead to confusion as to the outcomes of ovarian vein embolization specifically. Next slide. Just to do this in a other kind of detailed manner to see how this trial is being situated, you can see the components that we've already discussed in text format, but premenopausal female patients greater than or equal to 18 years old, they have to have chronic pelvic pain, they have to have pelvic varices, they have to have ovarian vein diameter greater than or equal to 6 millimeters. We're going to do CTVs and transabdominal ultrasounds in all these patients. They're going to be monitored for a period of time for 4 weeks pre-randomization. And then after randomization, you're seeing that patients are going to get randomized into blinded either venography alone or venography plus ovarian vein and or internal iliac vein embolization. With encouragement for bilateral ovarian vein embolization and internals if additional filling of pelvic varices is occurring on those internal iliac venograms after ovarian veins have been embolized. And then all these patients, both groups are going to be monitored weekly from a remote process. So we're going to collect really high quality data on all of these patients for 6 months. Then at 6 months, they're going to be brought in for a final full complete evaluation, repeat CTV and ultrasound, and then they'll be unblinded. And at that unblinded point, those patients who are randomized to the transcatheter venogram alone without embolization, they'll be able to obtain that embolization. Next slide. And so here you can see all those data elements and how they're going to be evaluated over time, and how you can see the ... on VAS, PROMIS 3A, PROMIS 10, and pelvic medication usage, that's going to be gathered on a remote scale weekly across the time point of enrollment to the end of their data collection point after the randomized intervention. Then once they're unblinded, essentially, once all these all this data is collected at that time point, at that 6-month time point, then those that did not undergo ovarian vein embolization, they only had venography, they're going to undergo crossover. And so they'll be able to undergo covered repeat venogram and embolization. And then we're going to track those patients, and we're actually including a 1-month evaluation at that time point to assess outcomes in those patients. And then hopefully my goal is to get some separate funding so we can get long-term data on all these patients and really understand how they do post-embolization and all. Next slide. So here's our primary outcome measures. I think we already talked about this, but you can see, again, those primary outcomes looking at chronic pelvic pain differentiation in this patient population based on very discrete criteria. Next slide. And I want to show the data that we're collecting because I think this is really important for all of us to understand. You know, intensity of pelvic pain, VAS pain scores, is the only thing that's ever been published over the past 20, 30 years. And the only data that we have is the 0 to 10 scale. That's why it's the primary outcome measure. But we really need better data to understand these patients' disease process and the total discrete symptoms that they have. And so we're going to try to collect these types of data elements that have been previously published, and we're going to get better idea of the full scope of pain that patients are suffering from, be it just positional, postcoital, menstruation, and other components. Next slide. We're also going to do the PROMIS scales. So I mentioned that earlier. So I figured I'd show some slides about the PROMIS scores. This is the PROMIS 3 and 3A. So you can see how this is very discrete, and we want to understand this disease process. And it's only a 7-day retrograde memory. So there's not blinding. There's not large data components of patients looking back 30 days, which can be confusing and maybe modify this data. So we're going to get really high quality data from these patients. Next slide. Same with the global health. You can see this questionnaire is a little more interesting and goes into other disease processes like mental health, mood, ability to think. So we're going to look at the scope of how this affects total patient function, total patient happiness or abilities or functionality or fatigue. So we're going to get a much broader sense of how this type of pelvic pain really affects patients. Next slide. And then lastly, we're going to use global impression of change. I think this is going to be a key component for us because this really tells us how do patients do in from randomization, from enrollment out to the end of this study. And so we're going to have some really good quality data based on this. Next slide. We're going to have a lot of secondary outcomes. I don't know if I need to go into this level of detail at this point. But I'm happy to answer questions about this. You know, I think it's going to be interesting to evaluate more components. How good was CT and or ultrasound at predicting response to embolization? How good or bad is pain medication in addition to our embolization and invasive procedures? And are we able to reduce the need for some of these pain medications? And then lastly, I think I mentioned that there's a CPP quality of life tool that's being developed. And we have all the components that's being tested as part of that trial that's going to be incorporated into this trial and gathered at the same time. So we're going to have really high quality data about that new CPP specific quality of life tool so that we can assess, is that going to be better than BAS and something we can use in the future. Next slide. Here's one piece about sample size, just so you can see it, something in our design. We're going to put 40 patients per arm, or 20 per arm for a total of 40 in the initial plan. We are going to do a sub-analysis halfway through, and if we need to, we're going to expand this out to 60 patients total. But I think we'll have a good outcome with the 40 patients up front, and I don't expect to need higher number of patients in this trial. Next slide. So just to finish out, I think there's a lot of future needs outside of just a randomized controlled trial of ovarian vein embolization. I think there's a future that we need to gather on long-term data, mixing both venous compression, iliac vein compression, and the outcomes of iliac vein stenting. Could we do a similar randomized controlled trial of that disease process on its own? Or how does it combine potentially with ovarian vein reflux? And how do we combine ovarian vein embolization with iliac vein stenting? How is that going to optimize these patients? Do we need to, as many of you know, do this all at once? and do it all in one setting and all during one procedure? Or can we separate it and start with embolization first and then do stenting second? Or should we be targeting stenting as the primary tool? And lastly, we need a better understanding of renal vein compression and how often should we be pursuing that type of intervention? Should these patients, a lot of them, be undergoing renal vein relocation or surgical intervention, or can they be stented? We don't have optimal tools for that, so stenting has complication rates that we may want to avoid. And when is it really important? Sometimes people have renal vein compression, and that's not really the primary reason for ovarian vein reflux and not the primary source, and we can get away with doing things like ovarian vein embolization, and retrograde collaterals end up bypassing that renal vein compression without any further renal vein symptoms. So I think we have a lot more to understand about women with chronic pelvic pain and venous origin pelvic pain, but we're working towards it and hoping to combine all these elements. Thank you.
Thank you, Dr. Winokur. It's my pleasure to introduce our next speaker. He joined the Center for Vascular Medicine actually about the same time that I did. He started with us as a medical scribe, and quickly it became evident to us that he was much bigger and greater than that, and he has now morphed into a data guru for the Center for Vascular Medicine, as well as an important resource at the Lac and Paul Vein Foundation. I think on behalf of Dr. Pappas and myself, I would say that he has become a really very important part of what we do from a research perspective. And I'm excited to see him speak again today. He's a wonderful speaker, and he's going to talk to us today about pelvic venous insufficiency outcomes that differ by age groups. And this is Mr. Levan Sulek-Velidze. Thank you.
Thank you very much. Thank you, Rick, for the introduction. Can you hear me okay? Okay. Well, thank you very much for the opportunity to present. My name is Levan, and I'm presenting on behalf of Center for Vascular Medicine and the Lac and Paul Vein Foundation. And today I'll be presenting a study where we identify and the incidence of presenting symptoms of patients depending on age of presentation. I have nothing to disclose. So just to give a little bit of background on this study, a pelvic venous insufficiency, or PVI, is widely prevalent, and it's a major cause of lower extremity symptoms and also pelvic symptoms in patients. And it mostly affects women with the 3-to-1 female to male ratio. And PVI has been identified as the cause of pelvic pain in up to 40% of women. And over 50% of these women also present, in addition to their pelvic symptoms, with symptomatic lower extremity varicose veins. So most of these patients present with a mix of pelvic and leg symptoms. We've also previously reported in a study in 2018 that our group published that 80% of women with PVI have an iliac vein stenosis. And it's also known that the prevalence of PVI increases with age. Yet the mix of presenting symptoms, pelvic versus leg, with age progression has not been thoroughly evaluated. So the purpose of the study was to determine if the types of presenting pelvic and lower extremity symptoms vary with age progression. The clinicians at our practice over the years had this sort of a sense that younger patients tend to present mostly with pelvic symptoms, while older patients have more leg symptoms. So this was our hypothesis, and this is the reason why we wanted to do this investigation. So this is a retrospective chart review. We looked at 1,190 women who underwent interventions for PVI from January 2015 through January 2019 at the Center for Vascular Medicine. We looked at a total of 1,772 interventions during this time period, and some of the parameters we looked at include age, treatment type, medical and surgical history, presenting symptoms, and visual analog pain scores. Here are patient demographics. This slide's a little busy, but I just want to point out we stratified patients according to deciles of age. The average age of our patients was 51.9 years. And there were differences, significant differences in the prevalence of comorbidities such as diabetes, hypertension, coronary artery disease, and hypercholesterolemia. But this is to be expected given that we're looking at different age groups. Patients in their 20s had a higher prevalence of endometriosis and ovarian cysts. I should point out, every patient who we treat undergoes a complete gynecological evaluation to rule out any OBGYN cause of their pelvic symptoms prior to any venous intervention. I'll also point out, kind of on the flip side to that, we've also had some patients who suffered with significant debilitating pelvic symptoms for decades, and they underwent all sorts of GYN treatments, and my clinician colleagues can kind of follow up on this, but they suffered and they underwent hysterectomies and other procedures before finally finding us, and they underwent vascular intervention. Their symptoms were resolved. So we have some testimonials from patients like that as well. So this just shows the prevalence of PVI by age. So the prevalence tends to increase with age and then becomes kind of levels off. So only 6% of patients were in their 20s. So this chart shows the types of pelvic symptoms by age. So the different colored bars represent each decile of age, and the groups of bars show each type of pelvic symptom. So what are the different types of pelvic symptoms that we're looking at? We have pelvic pain at rest, we have dyspareunia, postcoital pain, dysmenorrhea, vulvar varicosities, and the group of bars on the far right are the combination of all the other bars, so just any type of pelvic symptom. There are a couple of other symptoms which are not mentioned here, such as pelvic heaviness, fullness, bloating. So here we just looked at a couple of the major types, but there are others as well. As you can see, in each decile of age, the prevalence of pelvic symptoms tends to decrease for each of those categories. And then next, if we look at the types of leg symptoms by age, again, the different colored bars are the different age groups, and each group is a different type of leg symptom. And we're all familiar with the leg symptoms. It's leg pain, swelling, heaviness, spider veins, varicose veins, restless legs, varicosities, ischemic or venous stasis skin changes, and ulcerations. And then all the way on the far right, it shows any type of leg symptom. So for each category, the prevalence of leg symptoms increases with age. So this chart kind of takes all that together. So the blue bars show the pelvic symptoms, which tend to decrease with age, and the green bars show the leg symptoms, which tend to increase. So they're inversely correlated according to age. And this is kind of reiterating the previous slide where we're looking at the SEEP distribution. So most patients presented with C3 disease, and that kind of increases with age. Age is going back into the slide. So here are the different types of interventions. Most patients received a stent alone, about 55%. We used to do a little bit more embolization years ago, but in 2018 we did a study which showed that the majority of our patients present with a combination of iliac vein stenosis and ovarian reflux, and in that group of patients, the optimal pain reduction is achieved with stenting alone, and embolization should only be done if symptoms persist despite stenting. So there's going to be another talk in this session a little bit later, which goes into more detail about that. So here we're looking at the post-op pain scores. So this is just the pain scores of the entire population, which improved after treatment. And then up here we have pain scores by age cohort and by treatment category. So there is improvement overall, similar improvement, with the exception of this blue line, which represents the patients all the way at the top. The blue line, it's the 20-year-olds. So we are now doing a separate study, which we're currently working on, just to look at this group of patients and stratify it by pathophysiology, treatment type, and just dive into more detail for that specific group of patients in their 20s. So in conclusion, pelvic venous insufficiency presents as a spectrum of signs and symptoms, with pelvic pain and leg symptoms being inversely correlated according to age. And we suspect one possible reason for this is that younger patients with pelvic pain perhaps have not developed the pelvic reservoir or as many cross-pelvic collaterals. And over the years, as time goes on, they develop pelvic escape veins, which may somewhat alleviate those pelvic symptoms, versus leg symptoms, which, over the years, they just get progressively worse with years of chronic hypertension, venous hypertension. So what's the take-home message here? Take-home message is that PVI should not be overlooked in younger patients, especially younger patients who might not necessarily have leg symptoms, who might have pelvic symptoms, or otherwise they don't have manifestations of lower extremity venous disorders. So it's important to keep that in mind. Thank you.
Our next speaker, I think there's not a whole lot more that I can say that hasn't already been said about him today. I will just, maybe the prerogative of having the mic, just from a personal perspective, say that so much of what the foundation does, as I mentioned earlier, is voluntary. Everything that the foundation does is voluntary. And I would tell you that none of it's possible without the dedication and the passion of Dr. Peter Pappas and everything he brings to our group. The group of kids that I highlighted earlier, really a huge part of the benefit that they've had is working directly with him and getting his guidance, as most of them go on to a clinical life. And so, on behalf of all of us, I just want to thank you for that. And Dr. Pappas is going to speak to us today about the SVP classification system and how it can be applied to clinical practice. Thank you.
Thank you, Rick. So we've heard made mention of the SVP classification. Dr. Winokur mentioned it. So in 2021, the AVLS convened a multidisciplinary group to develop a valid and reliable discriminative instrument. And I want you to remember that word discriminative, because it's not meant to actually measure outcomes. It's a descriptor that's primarily used to identify incidence and prevalence data. So the main purpose of a discriminative instrument is to facilitate communications between clinicians by utilizing universally accepted standards. The development of this classification system that facilitates incidence and prevalence data, as I mentioned, and the enhancement of clinical research so that researchers can compare their data and compare apples to apples instead of oranges to apples. The instrument is not intended to assess outcomes. So again, I know I repeated myself, but I think it's very important to realize that. So what are some examples of this? So right now, the SEEP classification is well known to all venous interventionalists. That is a discriminative instrument. We primarily utilize the SEEP classification, and whenever you see them in research papers, it usually is used to determine the incidence and the prevalence of the disease in that particular patient population. The RVCSS is the outcomes instrument. So after you do it, so before you do an intervention, you assess what their RVCSS is, and then afterwards, to determine the success of your outcome, you reapply it. And there are many types of outcomes assessment. This is a physician-derived one. In other words, the physician asks the patient or examines the patient, as opposed to a patient-reported outcome or a PROM, in which the patient then fills out a survey on their own without any prompting. So there are multiple types of outcomes instruments. They all have their advantages and disadvantages. So right now, we have the SVP classification. It is a discriminative instrument, and as Ron had mentioned in his previous talk on the clinical trials, it currently does not have a companion outcomes instrument. The AVLS is working on that, but right now it currently doesn't exist. Now, this graph has been published. It's been shown on multiple occasions. What I want to emphasize about this particular classification system is that it focuses on varices. Okay, so it's symptoms, varices in pathophysiology. So even though in the P part of the classification system, it talks about anatomy, it talks about obstructive disease, but the main focus of this is varices. So if you have a renal vein stenosis, or if you have an iliac vein stenosis, that's not covered in the S and the V part of this. That's covered in the P part of it, which we'll get into in a moment. So, for example, this is a patient of mine that I did many, many years ago. It has a left iliac vein stenosis. This patient would not be well, let me back up a second. If you have hilar varices, you're included in it. If you may have a lumbar, it's not clear to me if this patient would be considered a V1 patient or an S1 patient. So again, it focuses on varices and not necessarily on obstructive or stenotic lesions. So for example, this is a patient, it's the same patient who I showed, who has a 2 millimeter left renal vein, and I'll show you another slide that has some pre-dilatation on it. This would be considered a V0 patient, not a V1 patient, because there's no hilar varices that you can see on this one. So again, so this is what the venogram looked like afterwards, and this slide is placed here so that you can see that you have to reapply the discriminative instrument afterwards because their classification systems can change. So if this patient had hilar varices and they were a V1, you treated them with the stenting and you did their embolization, and now all of that is gone, you reclassify them and they now have V0 disease. So this patient here has ovarian vein reflux. So this is a V2 patient, but to your right, where you have the MRI, you see that this patient also has May-Thurner's. And in our patient population, we've published on this numerous times, 50 to 60% of our patients have combined iliac disease with some evidence of ovarian vein reflux with or without a pelvic reservoir. So the P part of this would be the left common iliac vein, and the O, which would be the non-thrombotic part of it. So it reads like a sentence, but in my opinion, and you'll see in a moment, it makes it a little difficult to do some of these incidence assessments when you're not looking at all the causes of pelvic venous disorders, if you're only focusing on varices. So again, this is a venogram, and you see this is reflux in the left ovarian vein. So this is clearly a V2 patient. And then the P part of it would read left ovarian vein with reflux. Now, this is the same patient further down, but you can see there's a large pelvic reservoir. There is no designation in the SVP classification to specifically identify if you have a pelvic reservoir. All of this would be included in the V2 part of it, and then you'd have to write out in the anatomy part of it where the segments are that are refluxing. So now these are people who have pelvic escape veins. So you can see here from the arrow, this is in the this is a balloon occluder that's in the internal iliac, and the obturator vein is now lighting up with the venogram here. So this would be considered a V3B. So the V3 section has an A section, a B section, and a C section, and the pelvic escape veins are under the 3B. Vulvar varices, like you heard from Dr. Gasparis earlier today, would be a 3A. And then if there are escape veins that you see, that's a 3C patient. So this is just some more examples of where the escape veins would look like on venography with the I point and the P point, which you've heard about today. Let's just go through this a little bit. Okay, so V3A and V3B, how did they look like on physical exam? So this is, again, another one of my patients. You can't see it, but there is actually an escape vein in the gluteal fold there, and then as it goes out, it goes down into the side. So this is, and this patient also had a vulvar varix. So the 3A is the vulvar varix. The escape vein from the inferior gluteal vein is a 3B. So this patient on physical exam has combined V3A and 3B disease. This is a cross-pelvic collateral, so that constitutes a 3B, and this patient also had a vulvar varix as well. This patient has escape veins high in the groin from the inferior, pudendal vein, and so again, this is the same patient, also had a vulvar varix, so this is actually a 3C patient because of the escape veins. And this is what it would look like on fluoroscopy. Same thing, V3A, vulvar varices, and so forth. All right, so the main part of this talk is applying it to clinical practice. And the reason why I put this topic on is although the SVP classification now has been available for at least a couple of years, there are precious few studies that have actually tried to apply it to clinical practice. So this is some of the work that Levon and Shreya had done. We actually presented this, I think, about a year ago at the AVLS meeting. And let's take a look at what we found out. So again, in 2021, the SVP classification, now we're in 2024. And again, like I said, there are precious few studies that have actually applied this to a clinical practice. So limited data exists regarding its utility, and the goal of this investigation was to apply the classification system. So we applied it to a group of patients that we treated at the Center for Vascular Medicine who had pelvic venous disorders. So it was a retrospective review done from 2018 to 2019. Only female patients were selected due to a lack of complete venogram exams in male populations, and we limited it to 70 patients that we had complete data on. We looked at age, race, all the normal demographic stuff, and patients were then classified according to their SVP classification, and we then looked at the prevalence of each S and V class in this group of 70 patients. So the demographics are what you would normally expect in this patient population, nothing that was really overly exciting. Again, just to emphasize that we did see patients who had ovarian cysts. As Levon had mentioned, all of these patients had a gynecologic evaluation beforehand, but it is not uncommon to see concomitant disease of gynecologic disorders with a pelvic venous disorder. So if you do have a gynecologic disorder, it doesn't necessarily mean that you don't have a pelvic venous problem as well. So please keep that in mind. So the SEEP classification, this is just to emphasize, as Levon had mentioned earlier, 50% of our patients had evidence of lower extremity varicosities in addition to their pelvic venous disorder. So it's important that if you apply the SVP classification, and part of the classification, by the way, is if you have lower varicosities, that you use the SEEP classification in conjunction with the SVP when describing your patient population. So the same thing, RVCSS. And now let's look at the S class. So in the V0 patient population, there was 11%, and then the I can barely see this, I'm gonna move up a little, excuse me. So in our S0, there was 14.9%, the S2 is 24, S2 3A. So the S2 means you have varices in the abdominal area from your xiphoid basically down to your pelvis and below the renal veins. S2 3A means you have abdominal varices and evidence of vulvar varices. S2 3B means, again, abdominal varices with extraperitoneal escape veins. And then the S2 3A 3B is combination of vulvar varices with escape veins. And then just S3 and 3B, meaning they only had evidence of a vulvar varix and escape veins, but we didn't see anything intra-abdominally. And then finally, just the patients with the escape veins. Now, the escape vein number of 12.8% is pretty consistent. If you look at some of the papers from Dr. Labropoulos and some of the papers we've published, it's around 10 to 15%, so that's not uncommon. So what this really says here is that a large majority of your patients have some combination of S2 diseases, what you would expect, and there is an incidence of vulvar varices and escape veins as well. The V classification in our patient population was a little bit different. V0 disease means that we didn't see any varix disease, whereas the V2 disease, we did see a lot of intra-abdominal, but in our patient population, we see a tremendous amount of iliac vein obstructive disease, which is not captured in the S portion or the V portion of it. It may be in the S portion because that's where their symptoms are, but you wouldn't necessarily see it in the V portion. Oops, sorry. So when you look at the P part of the SVP classification, in this group of 70 patients, what we see is that a significant number of them had obstructive disease in either the common iliac vein or the external iliac vein, right? And either unilaterally or bilaterally as well. And then when we look at the prevalence of ovarian vein disease, again, in this group of 70 women, we saw 26 out of the 70 had evidence of unilateral reflux, and there was only about 9% that had bilateral ovarian disease. Now, some of this data may be a little biased because we routinely look at the left ovarian vein. We may have missed some, so the incidence of bilateral disease may be a little underrepresented in this patient cohort. But again, this is identified in the P part under anatomy. So when we look at, again, the obstructive areas, it's the same thing, I'm sorry. And then, so this was an attempt by our group to apply the SVP classification in clinical practice. And what you see is, if you have obstructive disease, it's a little bit difficult to capture it because you have to put it under the P part of it or under the anatomy part of it, and you have to kind of analyze that data separately. So it's not necessarily well captured in the S and the V part. Now, I think that's problematic because if this classification system is supposed to be used to capture all of pelvic venous disorders, it's a little clumsy in my regards. So 70 women demonstrated 14 different SV classifications. The most common was an S2, V2 found in 12 patients. Chronic pelvic pain of venous origin, S2 disease, was the most common symptom, present in 67% of this patient population. Pelvic varicosities, V2 disease, were found the most common, variceal pattern seen in 53 patients. And 10 patients did not have any pelvic venous symptoms, S0. 17 patients did not have any varices noted on the venogram. So a lot of the patients may have had a pelvic venous source, but may have also had some leg symptoms associated with it as well. So like I said, this was an attempt to apply the SVP classification system, and it is my hope that we're going to see some publications utilizing this, because just like we did in SEEP in 1995, SEEP has gone through 3 revisions over its lifetime, over the past 20 or 30 years. And my expectation is that once the SVP starts to be utilized, we're going to see that there's going to be some recommendations for some tweaking of the system going forward. So thank you very much, and I appreciate your attention.
Thank you, Dr. Pappas. Moving on, our next speaker is again Dr. Ronald Winokur, and he's going to be talking about ovarian and pelvic vein embolization, how many vessels should be embolized, and what's the data. Thank you.
Thank you again. Happy to talk about this topic. As you could tell from the research data and research trial that's upcoming on ovarian vein embolization that I'm helping design and fund and move forward, this is a very critically important topic for us to analyze and think about and how we're going to move forward. So go ahead and go to the next slide. You know, the best way for me to kind of start this conversation about how many vessels should we embolize and how should we target these veins, I figured the easiest way was to start by a case presentation and show my strategy, at least, of some cases that I do. And this will highlight the strategy of the upcoming trial that we're going to look at of ovarian vein embolization and looking at bilateral embolization. You just heard some really great data and looking at outcomes, and you can see how there is a good percentage of patients who need embolization. Just because we only see reflux in unilaterally, potentially in the left ovarian vein from left ovarian dilation, doesn't mean that if we treat one side, we're not going to have a high incidence of recurrence of disease. And hopefully we'll get to that, because that's going to be somewhere in the middle to end of these slides set, that I'm going to show you the data, and I'm going to show you what the interventions were that were performed and how that affects the way we strategize the future. So we really need that trial that I mentioned earlier to give us data to say, yes, we should be doing bilateral ovarian vein embolization or unilateral ovarian vein embolization or 4-vessel, including internal iliac vein embolization, up front in everybody to prevent recurrence. And we don't really have data to tell us that right now yet, but we're going in that direction. So here's an interesting case to start with, and I think this will help drive your thought process on what I'm talking about. So this was a 30-year-old female, 12 years of pelvic pain, improved with ovarian cyst removal at one point. She had 5 prior pregnancies, so you can see she's meeting all of the predisposing criteria that we specifically find with high incidence of pregnancies, long duration of pelvic pain. Started after the second pregnancy. She has left lower quadrant bloating, heaviness, and aching. She's rating this at its worst, 8 to 9 out of 10 on a VAS pain score scale postcoitally, and lasting for days in a postcoital setting. So she's clearly presenting with a very typical venous origin, chronic pelvic pain type of process. She also has perimenstrual pain and no improvement with pelvic floor PT. So she's tried other interventions. Next slide. Here we have some imaging. So I do kind of complete imaging of these patients with ultrasound. That's my preference. So I'm going to show you mostly ultrasound images. I have some CT and MR images of other patients. And I think I'm going to show CT images in this patient, just because a lot of them are pre-worked up by the other providers before ever getting to me. And so that imaging is there for review. So here you can see a transabdominal ultrasound. You can see the right common iliac artery. And is there left common iliac vein compression? It doesn't really look significant. There's not real, it's 5.1 millimeters in the central common iliac, the peripheral 7. So we're not seeing significant compression. Looking at color Doppler of the left internal iliac vein shows antegrade flow. And there's no change in color Doppler flow within that left central common iliac vein. So maybe this is not May-Thurner syndrome that we need to worry about. Next slide. If we then look at the left ovarian vein, you can see the left ovarian vein is huge, 9.8 millimeters in diameter. Here's some great flow in both color and spectral, and you can see retrograde flow in that left ovarian vein. Beautiful image right there of the valve with valvular incompetence. Next slide. And then if we look at the right ovarian vein, you can see that one's dilated also 7.2 millimeters. And like I was saying earlier in the last set of slides, you can, anytime that it's bigger than 6.5, it's likely to have some degree of reflux. So something to worry about. And here you can see images in the periuterine space, and you can see large left to right periuterine varices. So clearly there's large veins, and she has classic symptoms of venous origin pelvic pain. So the suspicion is this is somebody who truly has venous origin pain that we can intervene on. Next slide. Here's some color Doppler images. You can see how there's pooling of blood in those periuterine varices on both sides. Next slide. And then interestingly, trying to evaluate the renal vein, does this patient have renal vein compression? Here you can see before and after the SMA, between the SMA and the aorta, it looks to be equal in measurement. Yes, there's some diameter reduction, but doesn't look like true compression or true nutcracker syndrome, in my opinion. Next slide. Here's those CT images I mentioned, because a lot of these patients are going to get external workups and be worked up by multiple providers. So you can see dilated ovarian veins on both sides with contrast in it. So there's clearly reflux there. There's an image on the upper right that is the left common iliac vein under the right common iliac artery. You can see no severe compression there. So no significant left May-Thurner syndrome or left common iliac vein compression. And then the left renal vein, that question of compression is there. So I think it's worth evaluating to other degrees. Next slide. This patient, here's an image in the pelvis, so you can see those large varices periuterine on both sides, as seen by ultrasound. So pretty clear by CT as well. Next. This patient went for evaluation by another provider after seeing me and doing that workup, and venography was performed and no intervention was performed, with the idea that maybe this was all nutcracker syndrome and surgery was the only intervention. So I figured it's worth showing some of these images, but you can see the left common iliac vein injection. There's no real significant internal iliac vein reflux or pelvic varices filling. You see some veins crossing over, but they're really just small presacral veins. Then the left renal vein injection, you can see it's emptying into a refluxing left ovarian vein, but there's also emptying into the IVC and not large collaterals. And then when they catheterize the left ovarian vein, you can see filling of the large pelvic reservoir. Next slide. So she ended up coming back to me, and I ended up pursuing intervention in her. And so I wanted to rule out that renal vein compression again. So here's another injection. You can see really good emptying, no significant central renal vein compression, and just reflux down the left ovarian vein. I think I did pressure measurements as well, and there was no change. So we went ahead and pursued catheterization of the left ovarian vein. I like to use a balloon occlusion catheter, injected sclerostin into the pelvic reservoir. Next slide. And then deployed coils in that left ovarian vein segmentally to lead to complete left ovarian vein occlusion, as you can see in the last set of images. And there aren't huge perirenal collaterals, so we had good occlusion here. Next slide. And then we went over to the right side, and we got into the right ovarian. You can see very large pelvic reservoir, pelvic varices coming off that right ovarian vein. So we did the same process, occlusion balloon, sclerostin into the pelvic reservoir, coil embolization of the right ovarian vein. Next slide. And then after doing that, I like to look at the internals. And then in this patient, looked at the common iliac veins to make sure we didn't need to do any sort of stenting at the same time. and we were going to do long-term follow-up to evaluate if we need to go after that in the future. Next slide. So she thankfully did better very quickly. So here's some data from 2 months out. VAS pain score reduced to 3 out of 10 from a 9 out of 10, if you remember, with post-coital pain. And so significant clinical improvement in this patient population at a very short term, which is fantastic and great for this patient. So let's look a bit at the data. Next slide. If we look at data and we look at outcomes, this particular piece of data I think is really interesting as determining diagnostic criteria. And this data, I like the last piece of this that I have on the slide, the combination of postcoital ache and tenderness in the over the ovarian point with examination, 94% sensitivity, 77% specificity with venous origin chronic pelvic pain. So this is really where this particular patient population has pain. Next slide. So I wanted to show some data elements of what does the retrospective data on ovarian vein embolization show specifically. So here's some data sets. These are from the early 2000s. If you hit next, I think it's going to highlight the VAS score outcomes for us. And you can see that this is an important data set. So these are 0 to 10 scores that we see in these patients. You can see interventions over time will perform differently than what we do today. So 5% sodium moruate and some gel foam alone in those 2 early studies, and no coils were put in, yet these patients had really high quality outcomes. These were bilateral interventions in many of these patients, not unilateral interventions, but you're seeing reduction in VAS scores from 7.8 to 2 range. And then if you look at ovarian vein embolization with coils, you're seeing basically similar outcomes, 7 to 3, 7 to 1. So we're seeing really good quality outcomes, even with internal iliac vein embolization. Next slide. And we can go next again. So I think all of this was combined, and I'm going to show 4 studies that have done some really good combined systematic reviews. So here's the first one by Brown that was done in 2018, systematic review, 14 studies, 828 patients, 994 unique individuals, and you can see clinical improvement, 82 to 100% of patients. And what's interesting to me is what the data set shows. So coils alone, really high outcomes. Sclerosis, interestingly, in a small data set had high outcomes, and sclerosing plus coils had similar outcomes to coils alone. But this doesn't look at recurrence rates. So I would argue that the bottom group, sclerosing plus coils, will prevent recurrence more so than coils alone when you're leaving that large pelvic reservoir in place. Next slide. Here's another data set also from that same time frame, 2016, similar data set, similar systematic review, similar number of studies, 12 studies, also showing really high quality outcomes of coil embolization and sclerosant. We're seeing very high percentages, 88% persisting until 36 months out with really good outcomes. You do need to be aware of coil migration in 1.2%, and so it's something to be aware of. Next slide. Here's a more recent data set that just came out recently, about 2 years ago. This came out of Europe, systematic review, similar to these other 2, looking at coil embolization, again, for pelvic reflux disease out of Europe, 20 studies again, 970 patients. They did look at a combination of ovarian, internal iliac, sciatic, and pelvic vein embolization. So 4 vessel embolization was possible in this data set, as opposed to, let's say, 2 or 1 vessel embolization. So they were very complete. They did have really positive outcomes. Dyspareunia got better in 60 to 89.5% of cases, 5.47 reduction in VAS pain score. So very significant reduction in VAS pain score in this patient population, which is great. Again, coil migration occurs, so something to be mindful of when we look at ovarian vein embolization. Next slide. Another good data set published just recently last year, looking at a direct comparison of randomization, ovarian vein embolization versus endovascular versus surgical ablation. There are some biases to this in the way that vessels were removed and sclerosed and injected, even in the open group, which I think may show why both the endovascular group and the open group both had similar outcomes of pre to post intervention pain scores. So you can see on the table that 9-2, 9-1. So both have statistically significant improvements in pain scores. But endovascular intervention resulted in more efficient pain reduction and reduction in estradiol levels. So I think probably less invasive ovarian vein embolization with sclerosing is probably the optimal strategy that this data set showed, with similar VAS pain scores that we're used to, 9 out of 10 being the worst case. Next slide. So basically, in summary, again, kind of like what I said earlier, we really have a lot of data to evaluate. We really need to get better at true randomization, and ovarian vein embolization has some promising results, clinical improvement in pain scores for sure. But this alone may not be the only thing we should be doing for these patients. We need better outcomes. We need better measurements, better understanding of CPP scores, and what Neil Kilnani is working on to get a disease-specific quality of life tool will help us a lot. And so then we need to finalize all of this with combinations of OVE and iliac vein stenting, as you've heard, for nibbles. And where is this going to take us, and how do we combine these strategies for treatment? Thanks a lot.
Thank you. And finally, we have Dr. Gaurav Lakampal. Dr. Lakampal completed his initial medical training in Punjab, India, then came to the US and continued that at Beth Israel Hospital in New York. Moved on to interventional cardiology in North Carolina, where he practiced for about 6 years before joining us at the Center for Vascular Medicine full-time in 2014. Dr. Lakampal.
Thank you. So I have nothing to disclose for the study. The topic of my study is pelvic venous patients with iliac vein stenosis and ovarian vein reflux treated with stenting alone. So the majority of women with pelvic venous disorders present with ovarian vein reflux and an iliac vein stenosis, and this is what we had highlighted during our initial trial study, which was not a trial, but a retrospective study in 2018, popularly known as the Santoshi trial. And this then led to a practice change in which at Center for Vascular Medicine, we focus more on iliac vein stenting instead of embolization, and led to the spawning of a first smaller study, which we had published in 2021. And this study was a continuation of that, a longer-term follow-up and a bigger cohort of patients. So it is still currently ill-defined in the outside literature which venous pathology is the primary component related to patient symptomatology, and which veins should be treated first, and what is the extent of the venous intervention required, and long-term recurrence prevention, what to do about that. So our smaller study, which I had just mentioned, had looked at 38 patients and outcomes of 6 months. Pelvic pain reduction was seen in 78% of those patients, and these were patients who had presented with pelvic pain but had combined ovarian vein reflux and iliac vein stenosis. So the aim of this study was to determine the long-term pelvic pain reduction, and in a larger cohort of patients who presented with combined ovarian vein reflux and iliac vein stenosis but treated with stenting alone, and also to determine the long-term reintervention rate and the type of reinterventions required. So this was the hypothesis: women with combined iliac vein outflow obstruction and ovarian vein reflux will demonstrate a sustained improvement in visual analog pain scores with venous stenting alone with a low reintervention rate. So this study was presented at the AVLS last year, and it's up for publication in the European Journal of Vascular Surgery. So it was a retrospective review of prospectively collected data at the Center for Vascular Medicine from January 2019 to December 2019. 141 patients' charts were looked at. Women who presented with pelvic pain secondary to combined iliac vein stenosis and ovarian vein reflux, however, treated with stenting alone, were included in this study. So the assessment and interventions essentially were the same like we used for the previous study. Everybody had a gynecologic evaluation to rule out any GYN disorders. Pre-procedure, 1 month, 3 month, 6 month, 12 month, 24 month, and 36 month visual analog pain scores were recorded. A transabdominal duplex ultrasound was performed prior to the index procedure and at every subsequent visit. And the stent types, the diameters, and the lengths of the stents used, that was recorded, and ovarian vein diameters were recorded. So all patients underwent diagnostic venography of their pelvic veins, their left ovarian vein, pelvic reservoir, and as well as an intravascular ultrasound of the iliac veins. The pelvic reservoir definition was the same as our previous study, presence of 3 or more identifiable pelvic venous segments with or without any cross-pelvic collaterals. I'm just going to move. So this was the demographics, basically 141 patients, average age was 44, gravidas status 3.1, BMI was slightly on the obese side, about 30. 60% of them were Caucasians, about 13% they did not record their race, 10% or 11% African American, and the rest of the breakdown is given. The comorbidities, hypertension was seen in about 28% of these patients, 25% had arthritis, 17% had hyperlipidemia. So coming to the stent territories, meaning which part of the vein was stented, a majority of these patients underwent stent placement on the left side. The stent extended proximally into the inferior vena cava and distally into the left external iliac vein, 83% of these patients. About 13% of the patients had right-sided stenting, and then the remainder breakdown is given. About 3% had stent extension lower down. So we were using wall stents up to about early part of 2019, so there were a few wall stents included in this study, but majority of the stents were that were used in this analysis were nitinol stents. And Bard Venovo stent, the commonest size used was 16 by 140 millimeters, so quite long stents. For Medtronic's Arbre stents, we used 16-150, 30 patients, and 14-150 in 15 patients. And the longest wall stent used was 20 by 80 millimeters. But there were only 15 patients who underwent wall stenting at that time. So coming to the reintervention data, what was the reintervention rate? It was 13%, 19 of the 141 patients required reintervention, and the average time to the first reintervention from the index procedure was 14 months. And pelvic reservoir was identified in 80% of these patients who did reintervention, who did require reintervention. Coming to the laterality, 3 patients required ipsilateral stenting, 11 patients required contralateral stenting from the index procedure, and 5 patients required ipsilateral and contralateral stenting. The indications in all of these patients was symptom recurrence, and the reintervention type was distal extension on the ipsilateral side in 3 patients, contralateral stenting in 11 patients, relining of the stent in 3 patients who had required bilateral stenting. So none of these patients required ovarian vein embolization for persistence of symptoms after iliac vein stenting. So this again a little busy slide, but it gives you the details of the reintervention after the index stent. To summarize, all reinterventions, as I said, were secondary to symptom recurrence. 3 patients required stent relining due to in-stent stenosis, which is about 2% of the total study population. 7 of the 8 reinterventions required distal stent extension into the common femoral vein. And I have a talk later on, we'll talk about that. All but 2 reinterventions were in nitinol stents, Now, the only reason being that we used only 15 wall stents. It's not that anything wrong with the nitinol stent. So this is the crux of the study, this slide, looking at the visual analog pain scores of patients who presented with both leg and pelvic symptoms. The pre-procedure pain scores was 7.59, about 8 in the combined patients. And I'm sorry, after 6 months, it improved about 3, and then it persisted at 36 months to about 2.85. And when we broke it down to pelvic pain visual analog pain score alone, the pre-procedure scores was 6.4 pre-procedure, and at 6 months improved to 1.7, and at 36 months actually went down even further to 1.15. So I just put this slide because this is the original visual analog pain score outcomes from the Santoshi trial. I just wanted to show how we were able to replicate this stenting alone in those patients. We had those patients had a pre-procedure score of about 9 and improved to 1.5. This was a 6-month outcome. And with ovarian vein embolization and stenting, it was 8.6 to 1.6. And embolization alone had slightly less improvement, 7.4 to 3.15. So in our smaller study with shorter follow-up, and now subsequently this 36-month follow-up, we've been able to replicate pretty much the same visual analog pain score outcomes, which kind of validates what we do. So in conclusion, most women with pelvic venous insufficiency secondary to combined iliac vein stenosis and ovarian vein reflux demonstrated significant long-term reductions in pain scores with iliac vein stenting alone. 13% of these patients required reinterventions, and all of them were actually due to symptom recurrence, but majority of them secondary to contralateral lesions, meaning a new symptom of right-sided discomfort, right-sided pelvic pain, which happened to manifest later on. Only 5% required reintervention of the ipsilateral index procedure, and most of these are stent extensions because of inflow disease, and that caused the recurrence of symptoms. Early reinterventions were secondary to symptom recurrence, untreated residual disease, and the need for stent extension. There were 2 late reinterventions, which were secondary to the development of in-stent restenosis. None of these patients required ovarian vein embolization for residual or recurrent symptoms by 3 years. And our recommendation is patients with iliac vein stents should have frequent post-intervention surveillance scans in the first 2 years, since most reinterventions occur during this time. Thank you.
I'm going to invite Dr. Pappas and Levon to join us here. And while they're making their way up to the podium, I just want to remind all the online attendees, we have at this point about 300 attendees online, to please feel free to submit questions. We will get them promptly, and we will be able to review them. So while they're making their way up, I'm going to start with the first online question. And this comes from Scott Caudle, who's a virtual attendee. And the question is there a relationship between PVI and pregnancy? And if so, does the number of pregnancies impact that?
So I think most of the data, even though it's retrospective, is pretty consistent. In our studies that we've published, the average number of pregnancies is 3. And there's a lot of data to show that as the number of pregnancies increase, ovarian vein diameters also increase as well. So I think that's pretty consistent, that pregnancy and the hormonal changes that occur with pregnancies are related somehow to the development of a pelvic venous disorder.
Yeah, I would agree in general. I think we know this from lower extremity varicose vein population, kind of similar outcomes, that they may be able to resolve that after their first pregnancy, but as they add 2, 3, an increasing number of pregnancies, I think we see further venous dilation and further persistence over time.
So I have a question for you, Dr. Whitaker. I know in your Embolize trial, you said you're going to have iliac vein stenosis as an exclusion criteria. But what about patients who have been treated with a stent and have recurrent symptoms? Would you consider including them in your study?
Great question. I wish I could at this point. Because we're doing this at a very early stage in a small patient population for comparison and looking at VAS pain score outcomes, and the cost of this that's going to end up, because we're essentially having to cover all interventions as part of the trial, we really have to take a more focused analysis. But in the future, ideally, we will be able to do larger populations and look at that and say, those who failed iliac stenting, who have a stent in place, who have persistent pain, who then undergo ovarian vein embolization, it'd be great to know, does that resolve the pain in that patient group?
Thank you. You have a question, sir?
A question for Dr. Lankanpal. After putting stents, what is your protocol for anticoagulation?
That's an awesome question. I know it's a very controversial answer that I'm going to give you, but I'm going to give you my personal experience that what we do and what for non-thrombotic patients. That's the majority of the patients that we treat. Our protocol is to put them on 90 days of 10A inhibitors. If for some reason they are not able to afford it and the insurance doesn't cover, I try to give them samples as much as possible for at least 4 weeks and then switch them to clopidogrel, 75 milligrams for the next 2 months, for a total of 3 months. Our first scans are done at 6 weeks, and if that scan shows nice wide open stent, we end it at 3 months. It's a hard stop. We tell the patients, if, however, there is some issue of thrombus lining or instant restenosis already starting to happen, I may extend that. But 90% of these patients get put on 10A inhibitors for the first 3 months.
So what happened to aspirin? Do you put them on aspirin too or no?
Yeah, so here's the controversial side. So Gaurav and I are colleagues, we work on this. So we looked at this and we published about 2 papers on it. So the first paper was by Max Tran, and he looked at antiplatelet therapy, and he looked at various combinations of anticoagulants and antiplatelet therapy. And mind you, I'm specifically only talking about non-thrombotic patients. It doesn't make a difference. So that paper wasn't enough. So the next thing we did was the second paper is we looked at 400 of our patients. 300 who were on an anticoagulant, the protocol that Gaurav just stated, with the option of increasing the duration past 90 days if the individual physician thought it was necessary, versus 90 patients or almost 100 patients who were put on nothing. And it made no lick of difference whatsoever. So I don't think you need to be anticoagulated if you have a non-thrombotic lesion. Also keep in mind, these are not 4 millimeter or 3 millimeter coronary stents that can easily thrombose. These are 14, 16, 18 millimeter stents the sizes of garden hoses. So, and the flow is not that low that it predisposes them to thrombosing. So the stents that tend to thrombose, there was a very nice paper that was from New York. Windsor Ting, I think, was the first author on it. Every one of the stents that they had that had a complication was from a technical error during the procedure itself. So there was some intraoperative problem that occurred to it. Now, this is not the same case for thrombotic lesions, they're stents. The standard of care for a stent placed in a thrombotic patient is that not only do you anticoagulate them, but they probably should stay on the anticoagulation for the rest of their life at that point. And there is very, very good data from Bill Marston to show that in the thrombotic patients, the type of anticoagulant matters. He had much better luck with Lovenox than he did with the 10A inhibitors if he started the 10A inhibitors right away. He transitioned them to a 10A inhibitor after they got a period of time of Lovenox because of the anti-inflammatory effect of the Lovenox. So in the thrombotic patients, to me, it's pretty clear. If you don't anticoagulate them, their patency is lower and they fail more often.
Yeah, and just to reiterate that, I think that's a great commentary in the way you described that. And I think it's clear a lot of us who've treated the non-thrombotics and iliac vein compression in the non-thrombotic patient population, the outcomes data looks really strong as far as patency rates without any need for true anticoagulation. So I think it's possible we can get away with, I've gotten away, and maybe we combine a lot of this data and publicize it, but I've been able to get good quality, high volumes of patients who we've treated with just aspirin 81 and have had no rethrombosis rate at all.
Thank you. We have another online question, and this one is directed to Dr. Winokur, and the question is, what is the preferred approach of Dr. Winokur for ovarian vein embolization, femoral or jugular?
Great question. I prefer jugular approach just because it allows for easier access to both ovarian veins. I think if you're going to approach this and really just do the left, then I think it's easy to get to from the groin, and you can make that upside down U fairly easily. But if you ever want to get into that right ovarian, I find it much harder to get into from below than it is from above. And so I've had a much easier time with IJ access for all of these and being able to catheterize the right ovarian vein. So, and then get down, evaluate the iliac veins, evaluate the internal iliacs in both, see if there's common iliac vein compression all at the same time. And so it allows for a little more complete access and evaluation.
So Ron, can we get a little granular here? Could you just describe for us like what your favorite catheters and wires are when you're coming from the jugular approach, especially in cannulating the right ovarian vein? What's your preference?
Yeah. I mean, I'm generally using a glide catheter, just like a standard shaped catheter. I'm not going to go like a E2 or anything out of the ordinary. Usually just use that in a glide wire and identify the right ovarian vein. The hard part is just it runs exactly anterior to the spine. And so differentiating it from IVC catheterization sometimes can be confusing because it's not super lateral like the left renal and left ovarian can be and are. So I will just kind of catheterize them, then do a quick injection. Usually I can tell the difference. It's like just a little bit further to the right than the typical IVC, if that makes sense.
So I go because we doing the IVUS, so we focusing more on the iliac vein compression. So when we used to do this, we would go from the groin and use a Lima catheter to cannulate the left renal and then get into the ovarian. And sometimes we would put in a 4-French burn through the Lima to go all the way down into the the pelvic reservoir veins. But with the right-sided, I have not had much luck with going through the groin. So you're right, you have to go through the jugular route because of the way it comes off from the IVC.
I have a question for Dr. Pappas on SVP. Do you find yourself using SVP currently? And if not, or kind of responding to the criticism that I think we've all heard in terms of complexity, what changes would you make to it to make it more usable and help us in terms of communicating about commonalities of patients?
Yeah, so I've had a lot of long discussions with Dr. Meisner and Kathy Gibson when they were developing the SVP classification. And I told them that my biggest complaint with SEEP is that you can get rid of the E, the A, and the P because nobody uses it. It's more for clinical research process. And I feel similarly about the S, the V, and the P part of it. If you're going to focus just on the S and the V part, then the P part is a little bit difficult. But by not including stenotic disease and only focusing on variceal disease, it forces you to then do the P part of it and to do separate analyses. I've gotten a little spoiled with the C because as you see in most of the presentations that I do, I just present the C part of it, the classification part, and then usually the RVCSS, and then when I go back and I reevaluate them, I look to see if the C class changed. Trying to do something like that similar with the SVP is a little bit more difficult. So again, this is used to determine incidence and prevalence data. And it forces you to do those multiple categorizations. As you saw at the end of the conclusion, we had up to 12 S and V combinations. And I think that's a little cumbersome to deal with it that way. And again, if you're going to be looking at using SVP for all the pelvic venous disorders, I think you should include stenotic disease in the S and the V part of it. But again, Mark tells me that when they were making the instrument and they had the experts with the statistics, they intentionally didn't do that, and they wanted to classify it in the P part. My suspicion is it's not going to get wide adoption unless they make some variations to it. For example, if you did a literature search on the SVP classification, you'd see lots of papers about the classification system and very few of them that actually have used it in clinical publications. So I think it's hard. It's a hard system to do. And even with me, I still have to go back and refer to the diagram. Even though the app is there, it's just a very cumbersome tool to use.
Another virtual question, and this is more of a specific, it sounds like a specific patient case. So the question is, if I'm reading it correctly, what would your treatment sequence be if you had a patient with a nutcracker syndrome with a 6 millimeter mercury gradient in the IVC renal hilum? They have florid left ovarian vein reflux and existing May-Thurner syndrome or iliac vein compression. That I think probably all three of you will enjoy. So, Dr. Winokur first.
If I'm understanding correctly, it sounds like, was there actually a pressure gradient in the left renal vein?
Yes.
Yeah, so, I would probably lean in that patient and there's a common iliac compression. Maybe it's worth trialing common iliac vein stenting in that patient first, and if you have success, then great. If you don't have success, then you have to kind of revisit and looking at, could you have success with other treatment strategies, but you may have to pursue surgery or renal vein reconstruction in that patient population. The other alternative would be to try intraprocedural balloon occlusion of the ovarian vein and see if you get pressure changes in the renal vein, which is often what I do in this patient population if I suspect it. And if I don't see a pressure gradient change in the renal vein, then I'll pursue ovarian vein embolization. But it sounds like iliac vein stenting is probably the first step in this one.
Yeah, so I think I'd agree with that. I'd go with the iliac vein stent first, and then subsequently see how the resolution of the symptoms happens. We actually have a case whom we still follow, a lady who was diagnosed with May-Thurner's and Nutcracker syndrome and came in with pelvic pain, and she was so concerned about the Nutcracker, so we told her, let's fix your iliac vein first. And it's been, I think, more than 3 years now we've been following her. She still talks about a Nutcracker, but she's asymptomatic, so that took care of it.
So there are two things that kind of influence my thinking when it comes to Nutcracker syndrome. So the one thing that bothers me the most is that we don't have a dedicated renal vein stent. And there has been reported incidents of wall stents, which are primarily used at the time to treat these, of them migrating either into the IVC or up into the heart. So not having a dedicated venous stent, not having a dedicated renal vein stent is a technical concern. The other thing, there was a paper by Steve Doherty and I think Dave Gillespie in which they looked at, I think there was like 12 or 17 patients in which they had this scenario in which there was ovarian vein reflux, renal vein stenosis, and a high-grade iliac stenosis. And I believe in almost 80 to 90% of those patients, they treated it just with an iliac stent alone, and the Nutcracker syndrome pain went away. So at first when I saw this, I was scratching my head trying to figure out what could be the possible reason for that. And my explanation is that the ovarian vein, for me, is an internal escape vein. So just like you see the pelvic escape veins, if you have a high-grade iliac stenosis and you don't have an ascending lumbar, you have to reroute the blood some way, so you get cross-pelvic collaterals. But another collateral is through the pampiniform plexus up through the ovarian vein. If you have even a physiologic stenosis, it's Bernoulli's principle. If you have to get more blood flow through that area, you have to increase the pressure. And that may be the cause of it. So by decompressing the iliac vein and not forcing blood to go through the ovarian vein, you may not have as much flow through that physiologic stenosis, and therefore that may be the reason why the pain either decreases or goes away. So that's a complete and total guess. But, you know, again, when you're sitting at the bar after one of these conferences and you're talking to your buddies and you're trying to figure it out, that's the best I could come up with. But it is true, as Gaurav said, I've seen the exact same thing. You decompress the iliac and a lot of their renal vein pain tends to go away. Now, are there times when it doesn't? Yeah, but I have to tell you, in my experience, I don't know about you, Ron and Gaurav, it's few and far between where you actually have to go and treat that renal vein. And by the way, the surgical options are not better either. Transposing the renal vein, oftentimes you have length discrepancies, you have to put a patch, you have to put an interposition graft, and even Peter Glavitsky is recommending that if you're going to do the surgical option, you stent it anyway. So to me, I like to avoid the renal vein at all costs unless I'm absolutely forced and I've got nothing else to fall back on.
Couldn't agree more with that final component of it. I absolutely agree. I mean, we can't overtreat these. The renal veins tend not to have a high incidence of cause, and I think it's really iliac vein or ovarian vein reflux that we really need to focus on.
Thank you. Another online question. This is from, and I should give credit, the last question was from Drew Seward. This next question is online from David Heister. The question is, please comment on preferred techniques for pelvic reservoir sclerotherapy, whether it's STS, gel foam, and any volume estimation techniques. Dr. Winokur.
Great question. I usually will estimate until I see escape into the iliac vein. So once I start to see filling of the internal iliacs and anything getting into the common iliac vein outflow is when I may adjust or end my embolization. I like using balloon occlusion because that allows it to stay static. There's not as much inflow, so it slows the outflow, and we can really maximize opacification of the entire pelvic reservoir with the sclerosing cocktail. I use a mixture of contrast, gel foam, and STS. So I usually use 4 of STS, so 3% STS, 4 mL, so 2 vials, 16 of contrast, and then half a brick of gel foam, and that allows it to stay static within that pelvic reservoir. There are people who have other mixtures. This seems to work really well. On the left side, I find myself using somewhere around 16 to 20 cc's before I start to see escape. And then from the right ovarian, it's usually a smaller volume. Hard to quantify that volume quite as much. Maybe it's 8 to 12 mLs if I were to guess, just from number of cases that I've done. But it is some volume that you can get in there and allow static for, let's say, 5 minutes at a time before adjusting or taking down the balloon and making it move on.
Yeah, so I tend to do the same thing, but when I dilute the STS down to final concentration of 1.5, and I add contrast to the foam injection, and I tend to let the venography guide how much I tend to inject, because when you're injecting it, it causes an intense amount of spasm into the reservoir, but you could see the dye going through the cross-pelvic collaterals, and it usually tends to stop either midway or as it crosses over, and at some point you just can't push any more dye further than that. That's usually when I tend to stop. I agree with what Ron said. It usually takes between 10 and 20 cc's to kind of get that, especially on the left side. And then if you're going to also embolize the ovarian vein on the way out, I use a sandwich technique where I put a coil, then foam, coil, and foam, just to limit the amount of metal that we're dropping into the reservoir.
Okay, any other questions from the audience?
So, so this is for Levon. I don't know if it's more of a question or a comment, but at the national meetings, we're usually having discussions about how to deal with the young 20 to 30-year-old patients who have these chronic pelvic pain disorders. And one of the first things that Levon's data showed me is that when we were treating them with either the ovarian vein embolization or the stenting, there was always this initial improvement that you saw at 3 months, and then they went right back to kind of what their pre-intervention kind of scores were. So if you're going to be treating these group of patients, and they're usually the women, always be very, very cautious. I know every person up here has said, make sure you get that gynecologic evaluation. I cannot tell you how critical it is, because my suspicion is that in this group of patients between 20 and 30, either they're nulliparous or there's some other gynecologic disorder going on. I'm not saying that pelvic venous disease doesn't exist in this group. You just have to be very, very selective as to who you decide to intervene on, because I'm very reticent to put a stent in a 20-year-old because I don't know what the 30, 40, and 50-year patency is of these stents. And so just a word of caution in that particular patient population. 30 and older, they seem to respond better, but between 20 and 30, there may be other things going on other than a pelvic venous disorder that's causing their pain. So just more of a cautionary note. Thank you. All right, we're done. So is it when's the next session? So this is a break now, right? So for those of you who are online, we're going to have another break, and then we're going to return for the last session at 3:45. So thank you very much, everyone. Thank you, Ron. Appreciate your time. Be well.
Thanks. Happy to be here. Good working with you guys.